في البداية أحب أشكر الأستاذ الدكتور أيمن فخري اللي هو جمعنا في هذه الأيام اللي بيختلط فيها أحاسيس الفخر بالنصر مع أهازيج الفرح بمولد سيد الخلق صلى الله عليه وسلم. Actually, I am not going to present a talk rather than I am going to raise a question. And I'm going to prepare for this question, which is my slide. A famous question which usually asked to us while we are students: why animals do not got varicose veins? We know that varicose vein is the price that we pay as mankind because of our upright position. We all know that we have many modalities for treatment of varicose vein, and Trendelenburg operation is the operation that stood the test of time. What is the principle of Trendelenburg operation? I think that the principle is in this word: flush, ligation, and disconnection of the great saphenous from the femoral, and also the tributaries from the great saphenous. What if we don't adopt the principle exactly? If we leave segment of the great saphenous and we ligate it distal to the saphenofemoral junction? Two things could happen. The first thing is we may leave a blind loop which may harbor thrombus, and this could shower later on, which is actually a remote possibility. But more commonly, we may leave unligated tributary, which could be a cause for recurrence. The word recurrence is the key in management in varicose veins. We all know that we have 20 up to 60% recurrence in the first 5 years and may increase on prolonged follow-up. Leaving or missing non-ligated tributary is one of the inadequate surgical technique, together with a missing accessory saphenous or missing a double saphenous, which is rare. Tributaries ending directly into the common femoral vein within 1 centimeter above and below the saphenofemoral junction should be ligated to avoid these inadequate surgical techniques. Actually, apart from inadequate surgical technique as a cause for recurrence, we may have inadequate diagnosis, like operating on patient already with secondary varicose veins, and also progression of the disease and altered venous dynamics. And the most important word is new vascularization. And so, what is new vascularization? When we ligate and disconnect the tributaries, certain hematoma occurs, and then it gets organized and microvessels form, and these microvessels try to connect to the nearby tributaries. And hence, the idea of what is called avulsion technique in Trendelenburg operation. What is the avulsion technique? They try to dissect the tributaries as far as they can and remove segment from all the tributaries and then avulse the tributaries. What happens? This is the photo for the saphenous and the biggest area or biggest lengths of the tributaries which has been avulsed, and this is the picture post-operative after avulsion. We see multiple ecchymosis, and these resolve with time. And by the way, in our concern, we can combine a vascular clip applier in spite of avulsing the tributaries to avoid these ecchymosis and hematomas. Another point to avoid recurrence, which has been published in the last few years, is to insist on closing the cribriform fascia, which is the defect where the great saphenous penetrates the fascia lata to go to the femoral vein, whether to do it using foreign material which almost inert as silicone patch, or even to close it directly. actually the pendulum shifts from open techniques with all modalities avulsion and closure of the cribriform fascia to a more conservative one, which is endovenous ablation. We know that the open technique, we do it in the context of stripping. And saphenofemoral ablation is done during the context of endovenous saphenous ablation. What is the privilege of using endovenous ablation of the saphenofemoral junction? I think that the privilege, it is minimally invasive. It needs no operating theater. Actually, it needs no surgeon. The radiologist can do it. But you can't go directly as much as close to the common femoral vein. You are going to leave few centimeters to avoid the thermal impact or thermal effect. And you can't go to all tributaries. And you can't close the cribriform fascial defect. And what is the privilege of open? You can go flush, you can remove segments, you can close the cribriform fascial defect. But there is a wound, yes. It's a wound in the groin, which is cosmetically enhancing. And it can be done under local anesthesia. Now the choice is for you. Which way would you like to choose? Would you like, when you do endovenous saphenous ablation, would you like to complete totally endo? Or would you like to combine Trendelenburg with endovenous saphenous ablation, I mean the hybrid procedure? This is a question for the floor to ask. Thank you very much.